dash. Okay? So, AUB. If you go for leiomyoma, yun ang medyo may problema. The details of the SWAN study, I think I need to ask Dr. Tan about this because apparently, this article was included by Dr. Capito because through time immemorial, we always thought that adenomyosis caused heavy menstrual bleeding with secondary dysmenorrhea. In the SWAN study, they found out that adenomyosis is the reason why it's just incidentally found in final histopath is that apparently it's not the direct cause of the bleeding. But apparently it still deserves its own category in AUB-A. What the problem now is the myoma. Venous plexi, vascular dysregulation as the cause of the bleeding, or if because of the impact on the endometrium, that's not the focus of my lecture this afternoon. It's primarily now why when it becomes myoma, dun po medyo nagkakahirap. It's in the manual also of Malcolm Monroe that there are different classifications of myoma. You need to place SM or O. AUB dash L, SM, and then you need to put the number para siyang cancer staging. No? If it's 0, it's the pedunculated submucous myoma. If it's 1, less than 50%, di ba? Parang endometrial cancer. Pag more than half, 2. And then all the rest, from intramural to subserous, it becomes an O, but you have to put the number. I'll show cases later. This is more comfortable with me, the malignancy and hyperplasia. So there's no AUB-H. Pag hyperplasia yung sakit ng pasyente and causing AUB, it's still an M. There's no AUB-H. The von Willebrand disease is the one they're mentioning in coagulopathy. Ovulatory dysfunction is all here. I think PCOS is also part of this one. There was a category earlier. This one, I'm not sure. I'm sorry, I forgot to read the whole article, but I'm confused with the endometrial portion. AUB-E. What conditions can cause local disturbances in endometrial function to cause bleeding, which is not yet in all the other parts of the diagnosis? If I think about endometrial stromal sarcoma, it's malignancy. So the only endometrial pathology I can think of which is not part of any is endometrial stromal nodule. It's benign, it can cause bleeding, but it's not a malignancy nor hyperplastic. Other than that, I am not aware of any other condition unless the audience can contribute on what cases will fall into E. Iatrogenic is easy. There's something the patient is taking which causes. I'm sorry, there is something lacking here. Intrauterine device is something that can cause an iatrogenic cause of abnormal uterine bleeding, but it's not here. And then these are the non-classified. Pag hindi nyo alam, then it's AUB-M. There is a recent increase in AV malformations recently being diagnosed because of the good sonologic findings of our sonologists. Pag meron na po kayong DNC, wala namang makitang pathology at ang lakas ng bleeding, especially after DNC, suspect AV mal. No? And tell your sonologists you are suspecting AV mal so that they can look at the myometrium and even do Doppler studies so that you can determine. Even if the patient did not have GTN, a patient can still have an AV mal. That is a wrong concept po, no? Na dapat may GTN dati, na chemo, kaya may AV mal. That's the most common. But it can happen in vitro. Okay, so I will end with how this system could be used. Look at this one, single entity samples. This is diagnosed as AUB, leiomyoma, so it's L, 1 parenthesis because it's submucous. What does 1 represent? Less than 50% submucous component. Okay, kaya nga sabi sa inyo, magme-memorize na naman tayo ng panibago. Hindi lahat po yan. Matanda, bata, in training, recently in training, now the trainers, we have to memorize it because it is the POG CPG. Next, adenomyosis is easy. You just have to write AUB, A1. No, I don't think there's, because, why A1? No, there's no letter in A. It's just A. I'm sorry. Again, there's only A. Only the leiomyoma has numbers, okay? I don't know why. And to my knowledge, you don't need to come out with all of that to justify your answer. It doesn't have to come out with the chart, okay? Hindi nyo kailangan isulat lahat yan sa chart, but it's nice to memorize it. So this one is a single entity wherein you have a polyp. I'm sorry, I think it has to be AUB-B only because there's no letter in polyp. I haven't seen an invasive polyp, okay? So the M, which is the hyperplasia malignancy, is M, AUB-M. Now is the combination, the multiple entity. So pag alam naman natin, yung iba may myoma, may endometriosis, sometimes may hyperplasia. So like in this one, there's a malignancy and there's a myoma which is submucous. You have to write it according to how it was ordered in Palm Coein. Okay? It's not a rule of bulk. Hindi dahil mas malaki yung myoma, dapat una siya kung sakaling may polyp. Okay? You have to follow the order of the Palm Coein. So even if malignancy is the indication why you had to intervene because it's malignant, it's still AUB-LM. Okay? You follow the letters. So again, this one, polyp and adenomyosis, it's AUB-PA. Very easy. And then this is the one that's difficult. If you have a lot of myomas, then you have to indicate all. But this one, it's the polyp and myoma. But for example, you have multiple myomatas, which is more often than not the case, then you have to write all of the letters. It's L with all of the numbers following. Okay? So this one is adenomyosis with a von Willebrand's disease. Apparently, they found a coagulative disorder. So pwede pong tatlong letra. And in the end, I'll just try to share with you the laboratories that needs to be tested. One way or another, I think this was brought about. It's all in the CPG of AUB. The sampling, the sonohysterography is usually based on what pathology you're trying to investigate. There is a difference now in the CPG and the Palm Coein. In the Palm Coein, they're saying that you should do a biopsy when there is a woman more than 40. We're a little more aggressive in the POG CPG because they followed our setting here. And what's not in the CPG is something I would like to put in as an advice. For us in SGOP, any patient with abnormal uterine bleeding at age 35 and above warrants an endometrial biopsy. Because hyperplasia and cancer starts to increase at age 35 and above. So it's not the 40. And office biopsy, you can use your Novaks. And nowadays, we are popularly using pipel. No? The pipel kasi, you don't need to spray it. No? You just need to infuse it with a little fluid and extract it. And if I'm not mistaken, in the POGS convention, one pipel is 200 pesos, roughly. No? If you get it in bulk, no, you can get it. There's, I think, pipel there. Patients have more tolerance to the pipel compared to the Novaks, and the accuracy is the same. This is the medical management of acute AUB in the CPG. I will not go into the discussion of these two all the way to the use of our tranexamic acid. I just need a take-home message. Tranexamic acid is not given 500 milligrams TID. That was how we gave it before. And apparently, the reason why it's not working that much before, because we are giving it at a lower dose.